Hello and welcome to Chapter 9. This is micro lecture number 4, and in this we're going to finish out the joints chapter, and we're just going to look at other types of joints. And what I mean by other types of joints, these are the specific joints that you are really more likely to run into issues with. You'll hear them all the time. These are the ones where if you're going to get surgery on joints, they're going to come from this lecture. So let's get started. First off, TMJ, or the temporomandibular joint. This is going to be in the jaw. Some of you might have heard like clicking sounds in your jaw. You might have headaches because of this, but this is where you're going to have the condyle of the mandible with the mandibular fossa of the temporal bone, and that's just that articulation between the two, or where they both come together. And if you think of it, it's going to combine elements of the condylar hinge and plane joints. So this is going to be a combination of 3. Sometimes students will start trying to peg these special joints into one category, but because they're special and because these are the ones most likely that are going to get injured, they mostly are going to come from multiple types of that have elements of each type of joint that we talked about earlier. It also, as synovial cavity of the TMJ, is divided into superior and inferior chambers by articular discs. These are just going to be those cartilage of the discs and that synovial fluid between them that kind of keeps them moving smoothly past each other. You're going to have 2 ligaments that provide support. The lateral ligament, which prevents the posterior displacement of the mandible, so backwards, and then the sphenomandibular ligament, which is going to be on the medial side. So this one holds it back, from going out. A deep yawn or strenuous depression can dislocate the temporal mandibular joint, and the condylars will pop out of the fossa and slip forward, and also relocated by pressing down on the molar teeth while pushing the jaw backwards. So this is why you can kind of pop them out and then you can kind of put them back in. But let's just take a look at it. So it's going to be back here, the temporal mandibular joint. You can see the 2 ligaments, the one that's going to be on the outside for posterior movement, and the one in the medial, which is going to make sure it doesn't go outwards. And you can see how it's kind of sitting there by the 2 synovial capsules, the one on the top and one on the bottom. And then you're going to have the articular cartilage, or that cartilage that surrounds the actual bone. And you can see, just by deep yawn, you can see it popping out of that little space right there, that little fossa. This one, some of you have already had this or dealt with this, and it's a syndrome. And then this TMJ syndrome affects many as 35 million Americans. And the signs and symptoms can cause moderate, intermediate facial pain. This is that clicking sound in the jaw. It can limit the movement of the jaw. It's often going to be severe headaches, vertigo, that dizziness, the tinnitus, the ringing of the ears, and the pain radiating from the jaw down the neck, shoulders, and the back. And a lot of people who've had this, it's all because of this joint. It's all because of chewing. And there's many different things you can do to build up these ligaments, to build up the muscles around it, to make sure it doesn't get dislocated, and also to make sure that those synovial joints don't start to rub and they don't build up any types of crystals or anything else in them that can build up friction. The other one that's special, the shoulder. The glenoid humeral or humeral scapular joint, and this is the glenoid cavity with the humerus. So right there you can see it. You can see part of the rotator cuff on top. We're going to talk about the rotator cuff in a second, but this is a hemispherical head of the humerus articulating with the glenoid cavity of the scapula. Most freely movable joint in the body. This is very important to kind of move, or to kind of notice this, but because if you kind of move your shoulders around, you have more movement in your shoulders than you do in any other joint in your body. Fingers, hands, ankles, knees, hips, but the most freely movable is going to be the glenoid humeral joint. has a very shallow glenoid cavity from bones, if you can remember back that far. And the head's going to go into it. And you're going to have that, just because it's so shallow, you can move your shoulder up, you can move it down, you can move it forward, you can move it back. And because it's so shallow, you're going to be able to gain a lot of freedom of movement because of that. But because of that, it does have its downside, which we're going to talk about in a second. You have the glenoid labrium, which is fibrocartilage ring that deepens the glenoid cavity. And then you can kind of see that that fibrocartilage in there, that ring that deepens the glenoid cavity. All right, and it's right there, where you can see the glenoid cavity is right there, and then this just kind of sticks up and just makes it a little bit more solid of a joint. But what do we normally talk about when we talk about the shoulder? We don't talk about the tendons that much, but we do talk about the rotator cuff muscles. Sometimes we talk about the rotator cuff tendons, but if you remember back to muscles, you have the supraspinatus, which is in the supraspinatus fossa of the scapula. You have the infraspinatus, which is just below that, below the spine, and this is going to be on the infraspinous fossa of the scapula. Teres minor is going to be on the back, on just below the infraspinatus. We'll look at that in a second. And then the subscapularis is on the other side, the one that's going to be facing anteriorly on the subscapular fossa. But the supraspinatus, infraspinatus, teres minor, subscapularis, the rotator cuff, because all of them are going to insert at the head of the humerus. So the real reason why we have the rotator cuff muscles is because they're the one providing all of the structural support for keeping the head of the humerus into the glenoid cavity. And where do the rotator cuff tendons enclose the shoulder joint? Right around the head. So all of these are going to insert. You can see the supraspinatus tendon going to the top right there, and then the rest of them are all going to be on the sides or around the front or the back. And that's where all of them are going to be located. So there's 5 principal ligaments of the shoulder. 3 of them are called glenoid humeral ligaments, coracoid humeral ligaments, and transverse humeral ligament. They're not in red, so they're not super important, but I do want you to kind of know that these ligaments are just going to be here because they're going to go to the glenoid cavity to the humerus, the coracoid process to the humerus, and the transverse just goes across the humerus. And then you also have 4 bursas. If you remember bursas, these are going to be the ones that are going to provide little movement between the muscles and tendons. And here's one bursa right there. The next slide is going to look at more of them. And these are just going to be providing free movement. They're going to have the same type of fluid, similar fluid as synovial fluid, but it's just provide that frictionless movement between muscles, tendons, and bones. And here you can see the bursas a little more, where you can kind of see how they're going to provide the ability for those tendons to move around. You can see the subscapular tendon right there going into this part of the humerus. This is going to go to the front, to the subscapularis. You're also going to have the other rotator cuff muscles. But if you look at this, this is how your shoulder is actually into the joint. So if you lift your hand all the way up, all of these tendons are going to be in a very weakened state because they don't provide any support if you pull down or if you pull out. So a lot of the times, if you ever see like a parent dragging a kid by pulling their arm up, that's a very easy way to dislocate the shoulder joint. And you can see kids that have had dislocated shoulders, they do go back to having their shoulder dislocated when they were younger. Because once it's dislocated, it's very hard for it to maintain that stability. And then very painful, sometimes causes permanent damage, which I mentioned. Once it happens a lot. And then downward displacement of the humerus is the most common shoulder dislocation. I showed it to you on the other slide just so I could show you that you could see structurally all of the structures are attached up here. Nothing's attached down here. So if you lift your arm out and pull out, or you lift your arm up in this location and then pull it up, there's nothing holding it back. And the rotator cuff protects the joint in all directions but inferiorly, and the joint protected from above by the coracoid process acromion in the clavicle, but they don't have a lot of support to keeping it in. So if you pull out, there's nothing holding it back in. And then a couple of things we kind of mentioned. Children are especially prone to dislocation, and I kind of showed you that. A type of question I would ask on the test would probably be a rotator cuff question, where, yes, I asked something about, rotator cuff when we did muscles, but what about you usually hear of rotator cuff in pitching. Why would a pitcher for baseball always have rotator cuff issues? Think about that, and then kind of come back and maybe you can do it on a discussion or something too. But a lot of these injuries are because if you're throwing a ball overhand, you're not going to have any protection to keep the ligaments or keep that humerus into that shoulder. And after wear and tear, it'll break down, just like children who have that arm dislocated or that shoulder joint dislocated. They're prone to have it more and more as an adult. And some of you have had this, waking up this morning. If you've ever slept with your arm like above your head and then you woke up too quickly, sometimes your shoulder can dislocate because you might have pinched the blood supply to the muscles, and then the muscles can't keep the arm, tight, so your arm will be dislocated when you wake up in the morning. So a lot of shoulder dislocations. It's a very common thing to see in any place where you live. Next, let's go to the hip. So the coaxial, and this is going to be the hip joint, and this is the point at which the head of the femur inserts into the acetabulum of the hip bone. And if you remember, the acetabulum is part of the ilium, ischium, and the pubis when they come together, and they form that little indentation for the head of the femur to go in there. It bears much more weight and has much deeper sockets, so it's much more stable than the shoulder. And also, you can't put your leg all the way above your head. When you do it, you either have to move it forward and you can put it up there, and that can be flexibility. But if you think about it, your shoulder can just go out and up. You try to do that with your leg, it's not going to go that far. And if you do get it too far, the greater trochanter gets in here and you dislocate the hip. So this is not as freely movable as your shoulder. So you have the acetabular labrum, and this is going to be that little horseshoe ring, just like the one on the shoulder was. That's just going to be fibrocartilage that makes the acetabulum a little bit deeper. And this is just going to be that ring around the outside. Dislocations are rare. Some infants have congenital dislocations. Ligaments supporting the hip joint, the iliofemoral and the pubofemoral, the ischiofemoral ligament, and pretty much I'm just saying these because ischium femoris, ilium femoral. So these are just the bones going to the femur. Pubo is going to be the pubic bone. So if you kind of remember what the bones were, a lot of these ligaments are just bone to bone. So they're just using a hyphenated version of each word, and then that's how you get the ligament. And if you remember, ligament is always bone to bone. So some more information about this is the fovea capitis. So the fovea capitis is one of the most important parts of the head of the femur, and hip surgery is more than likely caused by the fovea capitis. There's a round ligament, or ligamentum teres, that arises from here and attaches to the lower margin of the acetabulum. It contains an artery that supplies blood to the head of the femur. This artery is the most important part of that ligament. It's round because it surrounds this artery. So let's take a look at how it looks. So the fovea capitis is going to be in there. You're going to have all of these ligaments that kind of go around, and you can see why you can't move your leg all around in 180 degrees, because these will become twisted. And you can see how they're already almost look twisted, but when you move the leg up or move it down, these become too tight and you can't pull it anymore because you would rip these ligaments out of the way. Now, fovea capitis. So you have the fovea capitis right there. This is a cadaver dissection, so you can kind of see that labrium that kind of makes it a little bit bigger, because this is just going to be cartilage that sticks out. The acetabulum is going to be in there. You can see the round ligament, which is where the artery is going to be. But if you kind of think about this, there's a line right there. And we talked about this with bones, where the long bones grow in 3 different parts. The heads, so one on the top, one on the bottom, and the shaft. When they grow together, there's a line there that's, when you're a child, there's cartilage in there. When you're an adult, that cartilage gets replaced, slowly replaced, while you're growing, the bones are still growing. They slowly get replaced by bone. And once they're solid bone, that compact bone, there's no blood supply between these 2 areas. So there's blood supply down there from the shaft, and there's blood supply with the head coming through that artery. If the if the hip gets dislocated, gets pulled out like that, this artery will break, and even if the hip gets put back in there, that artery will not grow back. So what happens here, you have this articular cartilage on top of the bone that's also supplied by the artery. That will start to break down. And when the cartilage starts to break down, that smooth capsule that was in there starts to rub. And once it starts to rub, it'll create friction. Friction creates heat. It creates pain. And that's why people that have had hip problems, they usually have to get a hip replacement eventually because the pain becomes too much. Usually with hip problems, they don't get better. Just because you damage this blood supply there, you can do therapy all you want for the muscles supporting it, but once this bone starts to break down, and especially that cartilage on top, and it becomes bone on bone, it becomes a very painful process for walking. So that's the hip joint, or the coaxial joint. Now the knee. So the knee, very complex. It's tibia femoral knee joint, so the tibia to femoral. It's the largest and most complex diatherosis in the body. So you have the intercondylar eminence, you have the 2 condylars on both sides, you have a patella on top to stabilize the front movement of it, but it's primarily a hinge joint. So it's capable of slight rotation, that's from medial or lateral rotation, and lateral gliding when the knee is flexed. But pretty much it acts like your finger, where it's just a hinge joint. There is some sliding, but there's not much. So when you're looking at this, the joint contains 2 C-shaped fiber cartilages, the lateral meniscus and the medial meniscus. The lateral is going to be on the outside, medial is going to be on the inside. Go back to bones. Which bone is medial on the lower leg? The tibia is going to be medial. The fibula is going to be lateral. So the fibula has nothing to do with this joint because the fibula does not bear any weight. So both of these meniscus are going to be on the tibia, but if you're looking at a leg, you can kind of tell what's lateral just by looking at the bone next to the tibia. It's going to be joined by a transverse ligament. We'll show that. But that's going to be absorbing shock of the knee. It prevents the femur from rocking side to side on the tibia, and these provide a nice smooth cushion for you to jump, for you to run, and for you to do all of the different things that you do every single day. And you can see there's the meniscus right there. And because this is a sagittal section, we really can't tell if it's medial or lateral. So, okay, you also have the popliteal region of the knee. The popliteal is going to be supported by a complex array of extra capsular ligaments external to the joint capsule, and this prevents the knee from rotating when the knee is extending. So when you extend the knee or keep it straight, it's going to prevent the knee from rotating side to side. Fibular collateral ligament and the tibial collateral ligament. They changed the names a few years ago to tibial and fibular, But most of you will also use lateral collateral and medial collateral ligament. The reason why I say medial collateral ligament a couple times, MCL. We've all heard that if you watch football or soccer or any type of sport where there's running and there's knee injuries, it's usually going to be an MCL injury, and we'll talk about the ACL in a little bit. But the fibular collateral ligament is lateral because it attaches the fibula to the femur. The tibial collateral ligament, because it's going to be medial, attaches the tibia to the femur. We also have two intrascapular ligaments deep within the joint capsule. The synovial membrane folds around them, so they are excluded from the fluid-filled synovial cavity. And these ligaments cross each other to form an X. You know what they are: the anterior cruciate ligament and the posterior cruciate ligament. Anterior is on front, posterior is on back. The anterior prevents hyperextension of the knee when the ACL is pulled tight. This is going to be a common site of knee injury, and I'll show you on the next slide. Posterior prevents the femur from sliding off the tibia, and it prevents the tibia from being displaced backwards, and then untwist the ligaments. So let's look at all of these ligaments that are really important for the knee that you definitely need to memorize. So you have the fibula down here with the fibular collateral ligament, or lateral collateral. You have the tibia to the femur. So this is going to be the medial collateral ligament or the tibial collateral ligament, MCL, or you can do tibial collateral ligament. Then this is the anterior view, posterior view. So anterior view, you see the anterior cruciate in front, posterior cruciate behind it. On the posterior view, you see the posterior cruciate on the top and the anterior cruciate on the front. That's very important to kind of know what you're looking at. If you see a knee or you see a patellar ligament, patellar means the patellar bone, that's your kneecap, then it means that's going to be the front. So we're going to look at this back of the knee. So if we are running, and let's just say you're a football player, or you're a soccer player, or you're a track star, or whatever, usually your knee is okay if it sees something in front of it or something behind it. But let's just say somebody tackles you from the side and from behind, because that's usually when tackles are going to occur in soccer and football, because somebody's chasing you. And if you look here, if you have a force coming right here from behind, you're going to put tension on the anterior cruciate ligament and the medial collateral ligament. So that is the reason why in your lab class, if you're taking it in person, just kind of take those models and bend those ligaments, and you'll see if you put pressure on the outside and you bend the model back, this becomes really tight and this becomes really tight. If the force is strong enough, it'll damage this one and this one. That's why the anterior cruciate and MCL are usually the two that get damaged. Basketball, same thing. Somebody falls on you from behind, because if somebody's following you from the front, you'll probably move out of the way. So definitely make sure before you move on, you memorize those ligaments. They're very important. Now we can take a look at the C-shaped cartilages, the medial meniscus and lateral meniscus. Also during knee surgeries, these can also be replaced by a Teflon coated type of a thing. And now you can kind of see even more. If somebody is going to hit you, you can see anterior cruciate and the tibial collateral or the MCL get damaged just by twisting and just by tearing. And most of the time, if you can see it in the lab and you can kind of bend that model back and forth, you can see which ones are going to stretch on which type of movement, and you'll see which is most likely to be damaged. The only problem with this picture is you can see how this kind of goes in, so it's going to twist the body back. That's why the MCL is going to be damaged. And because it's going to twist it all the way back like that, the one on the front or the anterior cruciate is going to be damaged. And these are also going to heal very slowly because they don't have a lot of blood supply to them. So knee injuries and arthroscopic surgery. So this type of surgery is a procedure in which the interior of the joint is viewed with a pencil-thin arthroscope inserted through a small incision. Less tissue damage than conventional surgery. The recovery is quicker because these are pretty much, if you go in there very, very small, you don't have as much damage. You don't have to have the blood supply deficiencies that you have in the normal part of the knee. So the less damage you can have for surgery, the easier you can have for repair. You also have something called arthritis, and this is a broad term for pain and inflammation of a joint. So just like pneumonia is just going to be fluid in the lungs. Arthritis is any type of pain or inflammation of the joint. Most common crippling disease in the United States is arthritis. You have a rheumatologist, that's going to be the physician who treats arthritis in joint. And then you have an osteoarthritis, is the most common form. Wear and tear, many years of joint. The older you are, they break down eventually. You also have rheumatoid arthritis, and this is going to be the autoimmune system is going to attack against the joint tissue. The antibodies don't really know what's going on, so they start attacking the synovial membrane, and then the enzymes in the synovial fluid start to degrade, and this starts to makes the bone start to form bony or ossify. So this is very, very bad, and it can cause really, really bad joints. We'll look at it on the next one. A lot of the times they can be surgery for some, but it's mostly going to be steroids, aspirin to control the inflammation. It's going to be a lot of therapy and stuff like that to try to get rid of this, because once your autoimmune system is attacking itself, there's very little things you can do except for drugs to try to overcompensate the antibodies attacking the joints. And if you look, this is what it looks like when the joints start to fill up with bone. And you can see how rheumatoid arthritis just starts to make the joints all out of whack. And you can see the bony deposits starting to form there. And finally, we kind of mentioned this, where this is going to be the knee, where you can see the prosthetic knee. You can also see the head of the femur is in that. You can see how those two condyles go into this. It's an inert substance. It's like silicone, but it's a different silicone type of a structure, where this kind of sits into this, and then you can see how that would be a knee surgery. And for the hip, all you're doing is you're pretty much taking this, it has a spike at the end, you're sawing off the head of the femur. You can see there used to be a head of the femur there. You saw that out, and then you hammer that spike into the shaft of the femur, and that's a hip replacement. So you can YouTube those surgeries. They're very interesting if you're into that, but not necessarily on the test. But that concludes chapter 9. So good luck, and if you have any questions, reach out to me.